I'm Deborah Holden. Welcome. I'm the Dean of the NYU School of Global Public Health. I'm super excited today for us to have this conversation. I've spent much of my career doing work around community violence. When I started out, we weren't really allowed to talk about gun violence. It was sort of a hot topic. It got you into trouble. It got you into the radar of groups and people that you didn't want to be on their radar. And Dr. Cunningham and many others from her ilk said, I am, it shall be. We will deal with this problem head on, and we will do it with the best data and science that we can. So it's really an honor to have her. She's one of the true heroes and giants in the field. Before I introduce her, I want to acknowledge a good colleague and a friend, Dr. Mark Garevich, who is the chair of the Department of Population Health at the Langone School of Medicine. I always sort of joke, Mark and I are actually peers. What he runs is about the size of the School of Global Public Health. If you were over here, you'd be the Dean of Population Health. But he's been a real good friend and good colleague and remains a partner with the School of Global Public Health. So I want to tell you just a pinch about Dr. Cunningham, and then I'm going to hand it over to her. So she's the Vice President of Research at University of Michigan, which, if you didn't know, University of Michigan is the largest public research institution in the nation. It's like no small undertaking. Were you the first woman or the second? Second woman VPR. I mean, this is just like an amazing accomplishment. I don't have very many sheroes. Dr. Cunningham is one of them. And in that role, she fosters the excellence and integrity of research across all three of the University of Michigan campuses. She has extensive experience as a researcher, administrator, educator, and a clinician, including more than 20 years of experience as an emergency medicine physician at both U of M and Michigan Medicine and at Hurley Medical Center in Flint, which is where we met. Her research career is focused in large on injury prevention and specifically firearm injury prevention. She's the former director of the CDC University of Michigan Injury Prevention Research Center, which is a regional center. And I know her center actually has national reach and scope. She also established an NIH-funded national consortium to improve firearm safety. And she's a member of the National Academy of Medicine and currently serves as the co-chair of the National Academy of Medicine Task Force on Gun Violence Prevention. I could say more, but I won't. Dr. Rebecca Cunningham.
Thank you, Deborah. And just a pleasure to be here today for folks both in the audience and on Zoom. So let's see, we'll go ahead and get started. Let's see if I can get this. Where should I point this towards, folks? I'll tell you about my first slide first, perhaps, while it's up there. So as Dr. Verholden mentioned, I came to this field a couple different ways, but the first that I'll tell you about is as an emergency physician, and I practiced both at Michigan Medicine, which is in suburban Ann Arbor, as well as in Hurley Medical Center in Flint. And I practiced there for 10, 15 years and came to think a lot about gun violence during that time. So here we go, thanks, and I think my slides will work now. So I really want to give here kind of an overview of the topic and a data and public health framing and how we think about this and really how to think about a path forward on it. And I think I have about 30 minutes maybe of slides, and then we can have a conversation and we'll take questions then too. The first thing I want to do is just sort of back up. Everybody has their own thought on what gun violence is. And I want to just define it really clearly. So gun violence is a lot of different things. So gun violence is school shootings depicted down here in the left. Gun violence is intimate partner gun violence. Gun violence is community violence with a gun. Nope, I didn't do that. There we go. Gun violence is children who shouldn't have guns, finding them and accidentally or unintentionally, I don't like to use the word accident for any of you who grew up in the injury prevention world. Gun violence is suicide violence by gun. So these are all the ways that I'm going to talk about gun violence today, and for us to think collectively about it and hopefully break up some of the myths that people may have about what gun violence is and how to think about it collectively together. The other thing I always start from, no matter where I talk, and I give a talk like this, it's lovely to be here in New York today, but I give a talk like this all over the United States, in the most rural parts of Michigan, in the most conservative areas of the country, as well as in places that have entirely different views. And so wherever the place that we start, and really regardless of the audience, my framing is always the same, which is no matter who I'm having this conversation with, and as Dr. Verholden mentioned, it's a conversation I've been having now for publicly for, I don't know, 5, 8, 10 years probably, before that we could really say the word firearm very much without a lot of people getting squeamish. The first place to start is really thinking about what the perspectives are that you're bringing, and acknowledging that the rest of the people that are in the room around you may or may not have those perspectives. But often I'm talking to groups and bringing in perspectives of folks who hunt, especially I live in Michigan, which has a fair amount of, there's a national holiday in the northern part of Michigan on the first day of deer season. Folks who are teachers who bring a certain perspective then about what gun violence means recently. Also in my state at MSU, there was a highly publicized mass shooting, unfortunately, this past week. Grandparents, business owners, whether neighborhood watch leader, all people bring a variety of perspectives to gun violence, as well as their political perspectives, and the perspectives potentially of law enforcement. The perspective I bring, which I don't have that picture on here anymore, is somebody who stood in the trauma bay for a long time over a lot of kids and teenagers who were coming in and were bleeding. And at that point, the beautiful thing about the trauma bay at some point is there's not a lot of politics there. Everybody really has the same goal. And that's the goal that I've tried to get everyone to work on since then, which is let's all have the same goal, which is let's have less people arriving in my trauma bay, less injury, less death by firearms, and then also less of the trauma that's caused in our communities when we see and feel our friends and relatives also injured in those ways. So that's my goal. And no matter how diverse the perspectives are, and I stand in some rooms with some pretty diverse perspectives, that is the goal. Whoops. This is the goal up here that I try to get everybody to work towards all the time. And I find, and I'm going to encourage you folks to have a lot of conversations about firearms in your life and over the next decades. And when the going gets rough, what I always do is try to bring people back to this. And in doing that, I've been able to get a lot of forward momentum with a lot of different people and groups, because we really all have this goal, whether you want to carry open permit or not every single day, or whether you don't believe guns should exist in the country, we all have that same goal. And then since I'm standing in a public health school, it's always good to bring it back here too, is our former Surgeon General from some decades ago now, David Thatcher, is, of course, it's a health issue. And if it's not, then why are people dying from it? There we go. Did I go miss one? I'm jumping all around here. There we go. Well, one more. We're going to go through some facts. And I do this because people think they know the facts about firearms, but they don't really know the facts about firearms. And only in recent years have we been able to put together really good epidemiology on this, because as I'll show you in a few minutes, there weren't a lot of people studying it for a while. So here are the facts that we know today. And this is a New England Journal article. My colleagues and I were asked to put together, I think originally in 2016 or 17 now. The graph you see here is actually a revision of that. And we were asked to look at, well, what are the 10 leading causes? What are the leading causes of death in the country? At that time, this fact actually wasn't particularly well known. And I have QR codes throughout here, so if people want to get to the article, they can get to the article. But the thing to call your attention to here, I don't expect you to read all these blurry lines at the bottom, but there's things that you here in a school of public health and a school of global public health spend a lot of time looking at, and stuff that I spent a lot of time thinking about as a physician. You go ahead and sit down. And training as a medical student, as a physician, I spent a lot of time thinking about congenital heart anomalies, a lot of time thinking about asthma, a lot of time thinking about heart disease in small children, and cancer, number right here. A lot of my training as a medical student was focused on those things, which are all very important. As an early emergency physician, I spent a lot of time thinking about this thing too here, which was motor vehicle crash. But not so much thinking about this thing here, which was firearm related deaths. The other reason I really like this curve personally is it starts in 1999. which was the year I finished my residency. And the thing I like to point out to you, I know there's some students here, right? Some students in the room. So this is basically the course of my career. And as I'd have you think about it now, your career is maybe starting here. And what's the graph going to look like out to the right there? Because that's actually a lot of movement on something like this. Look at that for motor vehicle crash. Moved from, this is death per 100,000, right? A tremendous amount of death. When in the 90s, day after day after day, we had people dying in the trauma bay just in droves. And I could feel this difference in the course of my career, that it came down. We had less people dying in the trauma bay. I won't talk about why that is for lots of different reasons. But this is something you can have palpable change over the course of your career. And that's something the students in the room should know. So, but this here is really kind of a steady flat line almost, really, right? Is gun violence. And before that, it was high here too. It was about the same. So, but we didn't talk about it. So my entire career, we were also taking care of tons of people who came in and didn't come in and didn't make it in with gun violence and injury. And we weren't talking about it very much. And then here in 2019, you can see this is children who lived through infancy up to the age of 19. So minor children who lived through infancy in the US. It's often quoted publicly now as all kids and teens. Technically, that's not right. This is kids that lived through infancy, because really the childhood illnesses of infancy are a little bit different. Firearm injury is now then the leading cause of death in the country for every kid you see over a year old up to their 19th birthday. Adults aren't faring much better here. So this is among all ages. We see a similar line. Motor vehicle crash was very high. It has come down. In 2017, these lines crossed, and I'll talk to you a little bit more about that in a minute. But when we talk about it overall, the numbers you should know in the country are more than half of that is suicide, 44% homicide, all of it up 2014, 30% since 2014. 2017, those lines cross. The other way I tell people to think about this is whenever you see hear somebody who's died of motor vehicle crash, just know that you've had more people die that year by gun violence. Suicides, tremendously high in our veteran and military population that have an overall 50% higher rate of suicide, and 70% of those are by firearms. And then the thing that hits the news the most is mass shootings, which are, of course, all of these are very tragic. These are the ones that get the most publicity. And we'll talk more about community violence in a moment as well. Again, up tremendously. Incidents are up 52% in the past 5 years compared to the years before that. And then this is one of the reasons one of the many reasons I'm in town, besides getting to do this wonderful talk today, is to meet with other health systems leaders tomorrow in New York. And one of the things that here people are starting to pay attention to is the direct annual medical costs for gun violence are also tremendous. And why do I bring that up now? It's kind of like money. Why are we talking about the money? Because money is one thing that gets a lot of people's attention in addition to the daily human tragedy. This is a tremendous cost to society, and it's being borne by it. And we can't, of course, forget the ethnic and racial disparities that are here. And so this breaks out per 100,000. And some things that you also should know here for facts. Homicide rate for Black Americans is 6 times higher than other racial groups. This is the overall rate here. So this is your homicide rate, and then this is your suicide rate. Suicide rates, however, are quite a bit higher among Native and Alaskan Americans, and then also the rates for, and also among white Americans. But you'll see the other thing to point people to here is, regardless of the disparity, there's an awful lot of the other kind of gun violence in each of these groups also. So, and we'll talk more about that in a moment. And of course, underlying all of these are the structural factors, systemic racism, and then economic distress and poverty, and mental health access in rural areas that are influencing all of these disparities. Some of it has to do with a rural-urban divide. And again, this is a fact. There's a lot of talk, and depending on the circles that you're running in, that gun violence is an urban problem. Well, here's the data. So this is urban. This is rate per 100,000. This is rural. So how do we get to that difference? is largely driven by the difference in suicide, but actually people in rural America are dying an awful lot, and even more than people in urban America. This is important, I think, because, you know, if we're going to think about all of us and all of us in this together, and that first slide that I put up in the beginning to think about what your perspectives are. I've gone and talked in places in more rural America, and they say to me, "Oh, Dr. Cunningham, you know, bless your heart. It's so great you're doing that work that's going to help our cities." And I say, "Well, there's been an awful lot of firearm death in your community." And I pull up a map. They're like, "Oh, well, we didn't realize that. You know, it's awful high suicide rates in rural communities, but also, you know, pretty high homicide rates in rural communities also, and obviously also in urban areas. And then unintentional or accidental gun injuries happen in every community, really across. And, you know, one of the things about suicide, and I'll maybe get to talk about this in a minute, is, you know, almost more difficult to talk about than firearms is suicide in most communities. And so suicide deaths don't make it to the hospital. Often 95% die on scene. So most of the physicians and medical groups and people that would be activists in those communities don't necessarily see those. They may know of them in their practice. Families don't talk about the cause of death when it's suicide often much. So for many years, it wasn't discussed at all. And so the rates of suicide in across the country were often just not raised up very much. Back to this, what community, and this is really what community our children are affected by gun injury. And this was, again, that same article that I pointed out in the first one with the QR code has this data in it, which is when you look at firearm injury, when we first pulled up this fact, my team sort of sat back and we were surprised. This wasn't the data we thought we would find. And this is basically, so this is urban deaths so about 4 per 100,000 kids die in urban America by gun, about 4 die in suburban America, and nearly 4 die in rural America by gun violence. Now, again, those differences fall by intent. For those of you that study injury more, so some more of these are homicide and more of these are suicide. But when you get down to our kids and our communities as a whole, 4 per 100,000, and this is actually a couple years old, it's higher now, and a fairly even amount are dying. So all of our children and all of our communities are at risk for death by gun violence. Intimate partner violence, also, and I know there's increasing focus in the school here too on violence against women. So some facts that are good for you to know moving forward. So 50 women a month die by intimate partner violence. About half of those women die by firearms. The most common mass shooting in America is actually not someone who walks into a school and kills several people. The most common mass shooting in America is actually by a domestic partner, usually along with killing her family members and children. And this is the statistic among the many reasons I got into gun violence research. One of them was standing in the trauma bay far too often. And the other was growing up in a house where I thought I was going to be one of these statistics here in a house that had a lot of domestic violence. My mother used to cut out these clippings all the day and every week and send them on to us and say, see, look, we managed to not have that happen. We also know that in pregnancy, and this is another quite surprising fact for people that I really think you should know if we're going to cover the full spectrum of gun violence is if you are pregnant in America, the most likely thing you are going to die from is not your pregnancy or an obstructive emergency. The most likely thing you're going to die from is violence by your partner. And emergency departments see this far too much, and most commonly that's also by firearm. And then older adults, we talk about kids. Older adults actually account for 1/3 of all firearm deaths, and 70% of those, most commonly suicide, and 70% of those occur by firearms. So, you know, the picture you should have after going through these facts here is firearm violence is affecting everyone in the country. And this is not even beginning to get into the communities that are affected by having their loved ones or people that they know influenced by gun violence. Michigan, again, this is the state that I come in, and those of you who don't know Michigan, so Detroit's about down here, Flint is about down here, and this is as rural as Montana, so very rural areas of the country, and Detroit, very urban areas of the country. And when I throw up this map also, it causes a lot of surprise for people. So, you know, rates per 100,000, very, very much, you know, even across the state. This is something that's affecting everybody in the country. And also in my state as well, more people will die by firearms than they will by motor vehicle deaths. And until last year, unfortunately, the opioid epidemic has really raged on. In our state, more people would have died, and this is adults, the population, were dying by firearms than by the opioid epidemic as well. So how do we think about this? Well, fortunately, we have a lot of frameworks to think about this, working upstream, and this should be a model that's familiar to people here. Can't work down here. I got tired of working here and just scooping people up. Got to work way up here, upstream. Got to figure out why people are falling in, what's happening, and really work to advance it ahead of time. Again, with a clear public health approach, we focus on the data. We focus on moving data to knowledge and then knowledge to action. And people forget this with gun violence because I think it becomes so emotional for them. They think they start jumping to a lot of solutions that they think might work, as opposed to really working through a framework that we know has worked for public health over and over and over again over the last centuries. Define the problem. We know the problem. I just laid it out for you in 6 slides, right? Identify the risk and protective factors. It's not one thing. There's different risk and protective factors for each of those things. People often say to me, Dr. Cunningham, get me on some news thing. What should we do? What's the one thing we should do for gun violence? It's like saying, what's the one thing we should do for cancer? Are you talking about suicide by gun? Are you talking about, kids not taking guns out of their mom's purse? Are you talking about community violence? Those are different risk and different protective factors. They all need to be identified and worked through. Then we have to develop good test prevention strategies for them. We need to implement the promising initiatives, and then we need to monitor and evaluate and collect data on the effectiveness. That's the process. The process is not jumping to doing something, which is happening a lot now. And as we start talking about gun violence more, it's happening more and more. How do we think about what this framework is? And if you think about it from a little bit of a, I guess I'll get to that in a minute. So how did we get off track exactly? I won't give a lot of details, but in 1996, the Dickey Amendment was passed, which effectively scared the CDC. Congress scared the CDC enough to defund all of the firearm research that was happening in the country. That led to, by 2010, there were 135, that's not a million, that's 1,000, 135,000 total dollars for the entire country to study what was, remember, if you show me that orange line, the second leading cause of death among kids. So there was no money for this in the country, and we're sitting in an academic institution. What happens if there's no money for research? Oh, there's no researchers. So by 2011, there's no researchers working on this because there's no path to a career for it. There's no path to collect any data. And what happens with that by 2017, those lines crossed that I showed you, the motor vehicle line and the firearm line, those crossed, and nobody knew it. We actually figured that out a year or two after that, when we had funding and actually had an epidemiologist to start looking at the data. But in 2017, you'd think there'd be a big headline, right? Oh, guns surpass car crashes. There was no headline because there was no data, because there was nobody that would stand up and talk about it, because there was no research being done on it. There's really just a handful. There was less than 5 or 15 tops researchers in 2010 or 11 on this topic. So a lot of catching up to do. And I could talk a lot more about that history. Let's see, can I go forward? There we go. The other way to think about that kind of just puts it in stark realm for people is, these are other important public health things, although not, depending on where you live in the country, in the world. So total cases for these, for those 4 diseases altogether, about 2,000. NIH Research Awards, 320. Oh, total cases of firearm injuries, over 300,000. 3 NIH Research Awards between 1973 and 1990. So when people say, this is an impossible problem, how are we can't solve this problem. It's too big of a problem. It's not possible to move forward. Gun violence is insolvable. I say, well, really? It's not like we've tried. We haven't really tried very much here. We have a lot of catching up to do on trying. So we're working on catching up on trying right now. But let's not think it's any more difficult than any of these things. It's just that we hadn't tried very much. And if you don't try, you actually don't get very far. So the federal funding, again, in the same way, this is old, this was 2008 to 2017, federal funding for a motor vehicle crash. And this is an article that we did here that you can scan if you'd like to see the details. $88 million a year. This is trying. This is what trying looks like. We're trying to improve that motor vehicle crash death rate. Oh, we tried. $88 million a year. Cancer, we try really hard on cancer. Cancer is really important. Definitely want to advance cancer treatment, but we care a lot about that. Every time you go to the grocery store and you are asked to round up to contribute to cancer, which I think we should do, great idea, that's trying. We don't do that for gun violence. And so up to 2017, we were spending less than $1 million a year on it. So that's the difference between trying and not trying. And there's big movements on that. So over the past couple of years, we now have $25 million a year from the federal government on firearm violence funding, which is completely not enough, but it's definitely moving in the right direction. So we got off path. Path is curvy, it's windy, and we definitely got off track. But we're starting to get back on track again. So what are some examples of how we can move ahead and think about a problem of this magnitude and how we approach it? So if we think about what went right with motor vehicle crash and what we could do similarly, there's a number of parallels. But the first is we don't see crashes like this anymore. Anybody want to tell me why? Airbags is one, exactly. Also, this kind of front end protrusion, that doesn't happen anymore because car companies now have all kinds of subcompact things. We also don't put pillars like this right next to roads anymore. We have fancy roundabouts, and there's all kinds of research that's been done on a transportation level that has made this kind of crash not happen anymore. Do we still have cars on the road? We do. We have a lot of cars on the road. We don't have this kind of crash anymore, which was, I'm sure, instantly fatal. I don't expect you to read all this stuff on the left here, but the point here is in 1950, this is the first time the Chrysler car put in four-wheel disc brakes, right? So this was a tremendous rate. This is the fatalities per 100 million of car crash, just tremendous, right? When I think about the things that we did, and somebody was saying they were born in the 90s, I'm born a little bit before that. The things that we did before that for a car crash, we rode in the back of the car and we looked at the stars. I laid on my mother's lap in the front bench. There were no seatbelts. I mean, the car was entirely different then, right? We don't do that now. And guess what? Most of my friends' kids are not dying in car crash in their teens, right? So we did all these things that got down this way. We put in crash avoidance. We did crash worth improvements. We did behavioral modifications. Oh yeah, Moms Against Drunk Driving got going. They put in all kinds of laws here, but not just laws, folks, all kinds of other stuff. We worked on, it's not acceptable so much anymore to get in the car with a bunch of drinks. There's all kinds of now focused good substance use work that was done that decreased car crash injury. And this is the template for how we think about it. And also here, graduated driver's licensing laws. Again, none of this was taking away cars, because that's not a practical solution. So what's an evidence-based path forward? I'm going to keep saying evidence-based. Again, the solutions are going to have to be across what should be a familiar idea to folks in public health, across a socio-ecological spectrum. People jump here immediately. It has to be fixed policy. We have to mandate laws, blah, blah, blah. Sure, there are some policy solutions. We can talk about what some of those policy solutions are, but they're not all policy solutions. Public health has much bigger toolkit than that. Across a whole set of solutions. There are solutions at the individual level. We can talk about those at social and organizational levels, at community levels, and then also at a policy level. So as you're thinking about solutions, and you guys are going to be the one thinking about solutions for the next decade, because you're going to do that career for the next 20 years after that, you need to be thinking about what works on each of these levels. I'm going to give you a few examples here, and then I'll wrap up. So first of all, at the individual level, what we can all do across your schools and your workplace, you have to know the basics. You have to know the facts that I just told you there so that you can give good information out. You have to understand deeply that gun deaths are preventable. They are not, there's no such thing as an accidental gun death, really. Even when the toddler reaches into the purse and shoots it, that was a preventable instance. We need to support evidence-based programs. And the other part I'll mention here for those of you who grew up more in a substance use world that I did, anybody remember the DARE initiative? Right, I hope you do, in the School of Public Health, right? Well-meaning, excellent intentions. So we're doing a lot, we're repeating a lot of those mistakes right now in gun violence, where we're putting out programs that make people feel good, they make communities feel good, they make politicians get to stand up and say, I funded that, that's great. Do we know if it worked? Do we know if it hurt people? We don't. So, how about using evidence-based programs that we know are actually going to help people and not cause inadvertent harm? And then you have to start talking about firearm violence all the time. We're a little bit past the place that Dr. Verholden mentioned before, which is certainly in my early career. If I was in a federal building, working on substance use, working on injury prevention, we were not allowed to talk about firearms. We would be shushed. The doors would be closed. We were told that this was not the time to talk about this. I couldn't talk about it at a national conference. I couldn't have a poster on it. I couldn't submit an article with firearms in the title. It wouldn't get accepted. So that place is past, but we have to be in this place now of thinking about what the solutions are. So again, remove the word gun control from your language. It's not helpful. We don't talk about pool control. We don't talk about car control. Nobody likes to be controlled. If people are doing behavioral change at all in any evidence-based way, we don't like to be controlled. We can talk about safety. You have to change the narrative. I think this is a helpful analogy here. The AAP came out, the American Association of Pediatricians, they came and changed it for a while. For a while, this was their slogan, the safest home is one without a gun. That alienated immediately all of the people who actually had guns in their house who we were trying to protect their kids from. That's not a helpful strategy. They've since changed that plan. If you went into Florida and said, drowning is a problem, we need all of you folks here in Florida to get rid of your pool. How would that go? It wouldn't go very well. And guess what? You need the people with pools to actually do things that are safer. So you have to meet people where they're at and focus on safety and harm reduction. And you have to respect the views of a lot of folks in this country who are very responsible, who do have values. It doesn't mean you have to agree with them on the extent of those values and their ownership, but if you don't come to a place of respect across community interventions, when you're working to improve communities, you won't get anywhere, and you have to work on coalition building. Our teams work extensively with folks who are gun owners who would like to see improvements. If you're an organization, and this is actually one of the reasons I'm in New York tomorrow, is to think about what organizations can do. Beyond individuals, organizations have tremendous might and power and funding. So if we think about what academic health centers can do, and this, if you want to scan this as an article, and I know some of you have looked some more at exactly what the role is of academic medicine and healthcare in organizational and behavioral change, is if you think about the three pillars that we classically talk about, and hopefully some of the folks on the Zoom are at the health center. We talk about patient care, we talk about research, and we talk about medical education. And the way to talk about firearm injury prevention for healthcare organizations is to fit them squarely within that mission. So we have to think about what we do for our patients to prevent firearm injury. What's the best patient care for them? What's the best patient care for them at the time of the injury? That's the only training I got. Well, what should we do for them? I started doing a lot of work after that in the emergency department. What should we do for them before I send them back out to come back 3 weeks later? So that's a different kind of patient care. What should we do to mitigate their post-firearm injury and their emotional and mental health after that of their family? We have a role in healthcare organizations to educate the next generation of healthcare workers so they actually know something about evidence-based optimal care and can talk about this with their patients and can do trauma-informed care. And that requires education. I got zero education in medical school around any firearm work. We have a great short course now, in addition to what's over there, for physicians specifically on the essentials of firearm injury prevention. And then we have to have our medical schools and our healthcare organizations put a lot of money into research on cancer and put a lot of money into research on asthma and put a lot of money into research on all kinds of other things that are killing our kids. And so it's time for them to all step up, and more they are doing it. The University of Michigan has an institute in firearm injury prevention. There's a number of other academic institutes around the country, and they're coming more and more. And we all need one. We need one at all of our schools. We have to focus behind the hospital walls into the communities. And then organizations have the ability to advocate strongly as well in a way that individuals cannot, and they should use that voice to do so. So what can physicians do? Recognize the epidemiology and the risk factors that I talked about a minute ago. Become knowledgeable. I push this, like, you're going to counsel on car seats. You know how a car seat works. You're going to counsel on gun safety and a gun lock, but you've never seen a gun and you don't know how it works. Why don't you, we have a nice slide deck done by a pediatrician now that goes over like how a gun lock works, what parts of the gun it's on. You have to educate yourself if we're going to get somewhere on this. I'm going to move that over for now. You have to develop skills and get comfortable asking patients about their gun violence. I started some of the research I started in Flint was simply sitting down with kids and saying, tell me about what kind of violence you've had and what kind of interactions you've had with guns over the past 3, 4, 5, 6 months. And the kids just poured out information. Nobody had ever asked them those questions in a healthcare setting before. And then support evidence-based public health practices. I'm going to give you a couple other examples here, and then I'll wrap up, which is, this is an evidence-based, some people call them hospital violence intervention programs. If Kelly Duran is on the call somewhere here, she was a student when we first started this project in the early 2000s. It is a 30-minute MI-based, motivational interviewing-based session that we started at Hurley Hospital in Flint. That we found, and I have the QR code there, is effective in reducing violence, both intimate partner violence as well as community violence for kids 6 and 12 months later, costs less than an IV bag of saline. We have an implementation toolkit for it now. It's considered CDC best practice. And I have a flyer over there if anybody wants it to learn how they can roll it out in their healthcare setting. We've developed risk safety scores. Again, I got rather tired of stitching up kids and sending them back out, and without having any risk assessment on how much they might be likely to be involved in gun violence over the next couple of years. This is a 4-item screener that we developed for youth that are 14 to 24 in urban EDs that very nicely predicts their likelihood of engaging in a firearm interaction over the next 2 years. And this is being validated now with CDC funding in 5 other hospitals around the country. This is a free course. I hope if there's faculty here, you'll think about how you incorporate this, the materials in this course into your lecture. Sorry, it's zoomy there. Funded by the NIH. We took the probably leading 20 experts in the country on firearm violence. We have a massive online course that is free and available. That gives you all of the basics, as well as what works, what doesn't work currently, intervention programs, policy angles, community violence, police violence. It goes through the entire gamut. We use it as a 1-credit course. Some of our faculty in injury prevention or in other healthcare settings pull out different arms of it if you want to just focus on the suicide arm or you just want to focus on the other arm. I encourage people to take a look at it. There's also a flyer over there. Community violence, I could talk an awful lot about. We could talk about it at the interpersonal level. Here I'm giving you a community level solution. We know that community greening, and this is work that's been done by Mark Zimmerman and some others, as well as some folks here in New York, Charlie Brannis. If you take the old model, of broken windows, and you think instead about how you green that lot, these are community level interventions. It turns out if you green that lot and you clean it up from that, you improve mental health in the community in a number of different ways, but one of the ways that improves it is you actually decrease firearm assaults and robberies, and I include the QR code there as well. There's lots of reasons for that I could talk about. There are policy solutions. These are states with IRPA laws. You have one, we don't. After the shooting last week in Lansing, I do believe Michigan will pass an extreme risk protection order, is what that stands for. Red flag laws, people call them. That we will pass something this week, and I will be in Lansing this week to hear a little bit more about that. Some things, if you don't know about extreme risk protection orders, they are associated with reductions in state and city level firearm suicide. There have been used extensively in cases of mass shooting threats and also in cases of risk against violence against others. Again, not a lot of evidence out there because there hasn't been a lot of research, but April Zioli on our team has started to look at 330 of these risk orders that went into place and found that their initial target was across a whole range of settings. And we need more understanding on what works and what doesn't in terms of what the language is that goes into them, but these are certainly one of the policies. And then I'll finish here by saying, so this is, again, generationally, this was my mother's generation. Her physician encouraged her to smoke. It would help her delivery go easier. Physicians also smoked then. This is within our lifetime. Culture change is possible, but certainly hope isn't a strategy, and that's where all of you come in. So I will, if you want to learn more, we have a national conference, a newly formed research society for the prevention of firearm-related harms. We held the first conference last fall. And we will have another one. We had 500 people there last year in just outstanding science, and welcome any of you to come and join. It will be in Chicago. And I have a flyer for that too. So I think that's, this is the Institute. If you want to get more information on any of the stuff that we just said, is here. And then you can follow some of the stuff I talk about there. And there you have it. So I'd be happy to.
I already know you're amazing. What I'm really blown away by is your ability to put this information for us in context. You know, when you look at firearm injury, you know, relative to, you know, cancer, we're not sort of playing a, you know, battle of tragedy, but it really does bring it home. Like, we don't put our money where we say our real values are in this country, and it is preventable, and there's a lot that we can do. So just thank you for your great work and advocacy. It's uncanny for a physician and now an academic leader to be as actively involved and on the front lines as you are. So we really acknowledge you. Anybody really inspired and encouraged by her? Like, I'm just over here, like, I want to be just like that when I grow up. So thank you a lot for that. I got a bunch of questions, but I want to make sure that you all get to answer your questions, and I want to make sure that my partner, who has a lot of his folks from NYU Langone and who are in the health sector space, anything that is right there for you right now?
Lots of things, but I'm happy also to go to questions and work in issues, but also just underlining just the respect and power of what you present to us.
Okay, great. I'm going to be the mic person, I guess. Here we go.
You mentioned that data had been shut off in the mid-90s. Will you talk a little bit about why that happened, and are we facing the same threats today in terms of the collection of data?
So without spending too much time on it, as a field of injury prevention grew, which really grew up from motor vehicle crash work in the mid-80s, the country got tired, essentially, of having so much car crash data, right? So we formed at that time, the other thing I didn't mention is the country formed the National Highway Traffic Safety Administration, came out of that time, which is one of the reasons we had tremendous progress then in injury prevention in that area. And so as a generation of injury prevention people started working in the 80s and 90s, they started coming out with a lot of data that sort of suggested that there was a lot of people dying by gun violence. There was a political backlash to that. And with that, there was a push and a tremendous series of letters, really, that went to Congress, noting that that anything that had that Congress would no longer fund anything that was related to gun control. They actually didn't say gun research. That was the Dickey Amendment. They said gun control. However, with that was an underlying threat that if the CDC didn't take away its gun violence research portfolio, which it had, which was a couple $1 million at the time, that there was a covert threat that the entire CDC would be unfunded. And so with that was a substantial threat to the agency. And with that, there was a silencing of any concern out of protection for the rest of the CDC as an agency. That the research was unfunded, and with that, like I said, there was no research for years. Yeah.
Is that threat still present?
So the Dickey Amendment was formally undone half a dozen or so years ago. And if you read it literally, it actually never said you couldn't do research. It said that you couldn't advocate for gun control. And of course, we never advocate for gun control. We do research, we share data, right? So, but it was the covert threat on the backside of that. That has passed to a certain extent. So there are now, the agencies are now supporting firearm research, specifically the NIH is funding it, the CDC is funding it. You know, we had a conference last fall, and we had folks from agencies in NIJ, on and on. And so I believe we're past the time of acceptance of being silenced for that component, regardless of the political whims of the time, simply because of the urgency of the data that now exists and because of the daily news.
Yeah, John. And then we'll go to you, and then in the back row.
Thank you so much for your talk. So you presented some of your great work based in hospitals around firearms prevention nationally. Like, how are we doing about a better standard of care for victims of firearm violence? How are we doing?
There's a ton of work to do. Most hospitals have no violence prevention program. The hospital violence prevention programs that exist are still in an early state of evidence-based with a lot of opportunity for improvement in understanding what works and what doesn't work about them. So there's a ton of work to do. If you walk into 99% of hospitals and emergency rooms across the country, there will be no violence prevention program for you when you walk in that is treating you. And if you are a victim of firearm injury, there will be no supportive basis for you after that. So there's a ton of work to do in hospitals, which is why having health system leaders come together and understand the urgency and the opportunities here is really important.
I work at Highland Hospital.
Just the mic for the people on Zoom so they can hear you also.
I work at Highland Hospital in Oakland, if you know it.
I do.
And we have a lot of violence, every day it's another young, good-looking black man is dead. But my question really is so if you have all this money from the government, why aren't we getting money from NRA and all these other organizations, just like the car industry, whoever went, and I don't remember that history anymore, I remember when seatbelts came out. Why are we not, how do you look good? You look good by giving money to violence. Everybody buys a gun, why don't they get a little seat? And so why does the money have to come from the government? I'm not against that, I'm just asking. And why isn't it coming from these manufacturers of guns and the NRA, etc.? And I don't know if your research shows that.
Well, I'll say, money comes from lots of places, including the government, right? So there are a number of foundations that have stepped up in this space over the past couple of years as well. The Arnold Foundation, RWJ, the Joyce Foundation. So there are certainly private funds that have come into this as well. There are partnerships with firearm organizations such as the Sports Shooting Association, the National Association of Sports Shooting. I'm not getting the acronym quite right now. They've recently partnered with some of my colleagues in Colorado focusing on suicide prevention work. So some of that work is coming along. And some of the most conservative organizations in the country originally were focused on safety. So there's opportunities there and opportunities for more work on safety-focused work across the political spectrum, not just the government. Although foundations are always going to be a really important part of any topic, any research topic when I sit here with my Vice President of Research hat. However, the biggest societal challenges in our time have come from federal funding. And if we go back and look a little bit in one of those articles on funding there, if you do the QR code, there's a nice background on this, is when the country decided that HIV was a giant problem, there were certainly foundations involved, but there was PEPFAR funding, which is tremendous, millions and millions and millions of dollars up front, hundreds of millions of dollars up front. When we decided, and that's money foundations are not going to be able to come forth with. So the biggest societal threats we've had, from cancer to HIV towards motor vehicle crash, happened when the federal government leans in. And the NIH has begun to lean in, and with many kudos to NICHD, who leaned in early, and the NIJ, and NIAAA has been funding some of this for quite some time as well, so in relation to substance use.
We're going to take one more. We'll take two more in the room quickly, and then we'll get some of the ones on from the webinar participants.
Hi. So I want to go back to the first slide where you were discussing I guess it was between firearms, the spike in firearms between 2014, this one. I guess I'm really interested in knowing, because at this point you expressed that there wasn't a lot of funding at that point for firearm research. What was the breaking point? Like, what was the tipping point?
Yeah.
I'm looking at this graph right now, and I want to say I see the the significant change start to happen in like the mid 2010 range, but where, what, and because of firearm, like it's like kind of constitutional related, like what was that breaking point that folks decided that like this is what we need to start funding?
So first of all, this is a graph not of funding but of deaths.
Yeah, I meant, yeah, but like.
So are you asking, so what if I understand this, is what the increase, why we started having more deaths around here?
Right, because of the deaths, obviously funding is going to be provided. Well, hopefully funding is going to be provided. But that's the I would hope that would be the trajectory. So like I'm seeing a significant death increase happen, which in my mind would be like funding.
Yeah. It's a great question.
What was that tipping point? If that was not the tipping point.
It wasn't the tipping point. So you're looking at here, there's a big increase, and you're right. You would say, well, logically, right around then, we would really start funding this, but you'd have to have somebody producing this graph, and there was nobody producing this graph in 2010. So this graph, this table we put together in 19, I think it was 2017, it's the first time, or 18 that we first put this together, and it was publicly available data at the CDC that I had a team dig through and analyze in this way. And then it became better known, but there were no researchers looking at it then. So it didn't come out in 2010 or 11 or 13, 14 or any of those things. 2016 is when we started looking at this data. But you're asking a different question, I think, as well, which I think I can answer is, what was the tipping point in the country? Like, how did we went here, we had, $135,000 funding. And here we have at least $25 million of federal funding, and more if you look at the NIAAA and other funding that covers this broadly. And one of the things that's different is what happened here is in 2013 or 14 with Sandy Hook. I want to say 14. Mm-hmm. And people say, well, nothing happened after Sandy Hook, and that's just not true. So Sandy Hook was a tremendous eye-opening point for the country and for the national movement on this, which is both. It was great that it got us there. It didn't acknowledge the fact that as many people were dying in communities every day as were dying in Sandy Hook at the time. However, it captured the national attention in a way that was unavoidable and created a moment that the country couldn't ignore. And with that, a lot of pins came into place. Parents started organizing. So we had Mothers Against Drunk Driving. We now have an active parent group on firearms. They became, the national advocacy happened. Then when Portland happened a few years later, we then had groups, community groups that were organizing, able to put together things like a march. So those things take time, and here there were none of those groups in place because people were too afraid. But in this time here, those pins started to fall into place a little bit more. And so there was more positive momentum. In addition to, that kind of gets to where you're going. Yeah.
And unfortunately, we are out of time. Mm-hmm. If you wouldn't mind, only because I want to honor the fact that this ends at 1. So if you wouldn't mind, if we could stick around, if people want to stick around, maybe you can answer another 5 or 10 minutes. But I want to formally just say thank you for coming. I want to thank my great colleague, Dr. Duravich, who I found out today, in addition to population health, you founded General Internal Medicine.
Yeah, I had a chance to start a division of general. I wouldn't say I founded general.
It says founding director
of a division.
That's
true. That's true.
And then I found out you're also a physician and a public health person.
Also.
So I started my day off feeling really high about myself, and now I'm feeling very average.
Oh my God.
Very average.
Well, I want to thank you for the questions and also for the folks on Zoom. I'm sorry we didn't get to more questions.
Yeah, but thank you.
Thank you so much.